This is We Need to Talk with Dr. Darcy Sterling, where I give you the tools and skills you need to love better so you can live better. I love a good redemption story, especially when I know it's going to land on a happy ending. And when it comes to those kinds of stories, nothing epitomizes it more than addiction and recovery. One of the fundamental aspects to recovery is this notion that you first have to hit rock bottom, which is to say, before an addict can get help, they usually have to reach the worst point in their addiction to see that they're unable to manage their usage anymore, to realize that they are no longer a recreational user who has any control over how much, when, and where they use. They need to realize that their life has become unmanageable and that they need help if they're to have any chance of surviving their addiction. But what is it about needing to reach the lowest of the lows in order to decide once and for all that you're done using substances? Talk to anyone in recovery and they will tell you that there were many lows on the road to rock bottom, which for some might have been bleak enough to motivate them to seek help. Why then do some people need to hit a breaking point that often involves losing relationships, damaging their career, and sometimes bringing them face to face with death? Here with me today is Dr. Tamir Aldad, an addiction psychiatrist and CEO of Mindful Care, to help shed some light on this topic. Tamir, thank you so much for joining me. Hitting rock bottom is so prevalent a phrase we use in recovery. Why is it such a cornerstone in recovery? Why do people have to hit a bottom in order to get help?
Yeah, it's an interesting question. I think one thing that's really important is defining rock bottom. I think there's this misconception that rock bottom means you've lost everything. You've lost your family, your kids, you're estranged from everyone, you've lost your job, you're living on someone's couch. Sure, that is a form of rock bottom, but I think it's important to realize that rock bottom is a construct that for you, and especially if we were working together, what I would want to understand is, do you feel like you're at a point where you cannot function anymore? And that doesn't necessarily mean that you've lost everything, but are you paralyzed by your substance use? And if you are, and we use motivational interviewing to help somebody get there, but if you are there, that's your rock bottom, meaning this is consuming you entirely. And maybe if it continues, you'll lose everything. Maybe you've already lost everything. Maybe you're very high functioning and you're masking the entire thing, but you're at your rock bottom. And then once you're there, what's really important is helping an individual realize that their substance use defines them. It has become their identity. And this could even happen. I just mentioned high functioning. There are individuals that you wouldn't know that they're at rock bottom, and they are.
Yes.
Right? And that's individual. That person could be a high functioning attorney that has a flask in their drawer, and every 2 seconds they take a sip, and it looks like everything's great, right? You have that picture perfect life, but deep down, when you do some soul searching, you're actually in a very, very dark place and have no control. And that lack of control is your rock bottom. And what's important to answer your question there is you have to reach that point to really feel like it's time to turn things around. I think what happens is if you feel like you still are in control, it is very hard from a motivational interviewing perspective to convince you to change things. Because if you're able to have your cake and eat it too, which is kind of what happens in the scenario when you have some control, the argument to convince you that this is damaging to your health, damaging to your life, there's consequences, it's just not as strong of an argument where you can't pinpoint the actual damage that's being done.
Can you clarify or explain what motivational interviewing is and why it's important in both of our work?
Yeah, so motivational interviewing is a modality that we use in addiction psychiatry, but therapists across the spectrum use it as well to help guide an individual to better understand where they are, the consequences of where they are, and lead them to the point where the desire to change their reality is intrinsic, right? And you coach the individual to want to change by allowing them to effectively look in the mirror and see
Mhm.
their reality and what the reality is causing. And through conversation and questioning and reframing questions and reframing their answers, you're able to get an individual, ideally, if it's done correctly and the person's cooperative and it's effective, to start realizing, and even if there's that shadow of a doubt, that's plenty in the beginning of maybe something needs to change, or maybe there is an issue here. And if you get that ounce of doubt, that is a real step in the right direction.
And the motivational interviewing is important because this is going to sound like a statement, but it's really a question. It's important because intrinsically we are motivated by basically two fundamental things. We're motivated to pursue pleasure and to avoid pain. And so when it comes to an issue like addiction, motivational interviewing can help clarify, is what I'm hearing you say. It can help clarify to the individual that there are consequences to their behaviors, to their addiction. And it can help tap into either a desire to avoid some of those pain points or the pull towards the desired outcome that they want, the life that they nobody ever dreams of being an addict, right? Like nobody ever, no kid is like, yeah, I'm going to grow up, I'm going to be an addict.
Right.
Like that's nobody's game plan. So tapping into their motivation, whether it is the desire to live the life that they had always dreamed or helping them understand that there actually are consequences to their behaviors. Those are the two things that motivational interviewing most often does.
Yeah, and it's difficult to know before you really talk to someone where they are in their journey of recovery. There's people who what we call pre-contemplational, meaning they're not even considering becoming sober.
Mhm.
There's people who are contemplating sobriety, but you do sometimes try to engage in motivational interviewing, and the person's very dismissive, right? They'll tell you, "My husband brought me here. My wife brought me here. I don't think anything's wrong with me. I don't even want to be here. Not really sure what we're talking about here." And that's okay. That's a place to start. If someone doesn't think there's a problem, understanding, well, what's their day like? How often are you using? How's work going for you? When do you have to use? How effective are you? How are you doing in your meetings? Do you find it disruptive? Is it helpful to have to take breaks every hour because you have to use? What do you
Mm.
think it would be like if you didn't take a break every hour? Would you get more done? And it's just curiosity. You're no judgment.
I would imagine judgment would be antithetical to the work that you do. It certainly is
Yes.
to the
Yeah,
work that
for
I do.
sure.
People tend not to want to be vulnerable in the face of judgment and shame.
Yeah, absolutely. But I'm saying even that person in that situation comes in super kind of aggressive that I don't know why I'm here. I have no interest. And you try to disarm them and say, I'm actually totally okay with you using. I have no interest in you becoming sober, to be honest. I just want to understand how it's going for you and how you're doing a great job balancing your life and use. Love to learn more. How you're able to clearly able to do it all. Let's, walk me through what that's like. It could be exhausting for some people. It doesn't seem like it's exhausting to you. Help me understand how you do it.
But there's got to be something about substance abuse and addiction that requires a level of understanding of consequences to even have a phrase like hitting rock bottom because somebody can struggle with dysthymia, which is low grade depression, and seek out therapy. In other words, like the pain points don't have to be as severe when it comes to other issues for the person to seek out and engage in change the way it does with addiction. Can you help me understand why that is? Why does somebody need to be so low and to feel so out of control in their usage in order to seek help? And again, this is a gross generalization. There are certainly people who don't need to hit rock bottom. I understand that, but I'm talking about the vast majority.
For sure, for sure. We do have people who identify it sooner, and if they identify it sooner, that's good. But I think anecdotally, what I've seen is there's stigma. So coming forward is very difficult. There is denial. That the person is in terms of like self-awareness and insight. I think it is Usually, from what I've seen, an individual has more insight into the fact that they have anxiety or they're depressed or they're no longer interested in doing things than acknowledging that having 2 bottles of wine a night is a problem.
That makes
And
sense to me.
I don't know if I don't know if the data supports that, but I personally I've seen that patients can connect with the fact that they're anxious and have panic attacks very quickly.
Hmm. Yeah.
Harder for someone to see something wrong with smoking or drinking or cannabis use disorder, for example. It doesn't help now that it's legal and everyone has edibles and everyone can smoke and it's been rationalized. And in terms of like cognitive reframing, everyone now just says, well, it's legal and I just have to use it to go to sleep. And what's a couple of blunts a night anyway? So that there's the insight is very different, I think, when it comes to substance use disorder versus other mental health issues. And because of that, I think the loss has to be that much more dramatic to answer your question. I think there's the denial and the lack of insight and self-awareness for it to really impact the individual. And if you don't have a strong support system to call it out around you, needs to
Hmm.
be that much more obvious for you to realize that there's a problem.
I feel like that underscores a disparity in substance abuse from mental
Yeah.
health because we've come a long way with mental health. The fact that we're two clinicians, practitioners who work in the field of mental health, and we're both crystal clear that it is, generally speaking, harder for somebody to acknowledge and to bear the potential stigma of having had an issue with a substance. That seems like a much higher roadblock to overcome than we've done a really good job with mental health. I think that's the piece that I'm hearing and that I'm also feeling. I've seen it in my own work that
Hmm.
certainly, and even before the pandemic, but certainly a positive outcome of the pandemic is that we've all seemed to come on the same page and we're all aligned with mental health is it's a real thing. People have mental health problems that span the entire spectrum of both intensity and types of mental health issues, and there's no shame in it. But we haven't done such a great job with substance abuse. And that is what I'm hearing you say. Correct me if I'm wrong, that that's part of the reason why people have to feel so low and powerless.
Yeah, we're trying to change that, or and it's like turning a ship around. We're doing a better job. I agree with you,
Yeah.
especially with mental health. But in substance use, you'll see treatment plans are moving much more to being individual focused. We have customized treatment plans now. We're focusing on harm reduction, so people feel comfortable if they still need to use they can, and we create a space where only in the last couple of years have you heard the term that relapse is a part of recovery,
Hmm.
right? Creating a safe space where if you do relapse, it's not the end of the world. So within the addiction substance use ecosystem, we are trying to create an environment where people feel more comfortable. I don't think the rest of the world has caught up. And
Hmm.
that is why somebody can't be as comfortable. And I also think we've created an environment where if you try to come forward, there could be some serious negative consequences where you regret coming forward. I've had patients that are police officers, firefighters, a
Yeah.
pilot that
Big
their
issues.
their employer created a program for recovery and sobriety. They went and identified themselves as needing help. And the first thing that happened is they lost their job.
It's so fucked up. I have personally experienced
And
that. Well, personally
yeah,
through my profession, I have experienced that with pilots.
yeah,
They're like, I want to come see you, but it's part of my contract. I cannot see a therapist. I can't be on any
mm,
medications. And I'm just like, this can't be right. So I did the research and it turned out it's right. Like they
it is right.
literally they're prohibited from seeking
Hmm.
mental health treatment. But so what does that say about
I
pilots?
had it
Does
with
it say
police officers.
what did that look like with police officers, if you don't mind my asking?
That if I have a substance use problem, I can't discuss it. Next question. I
Wow.
was like, That is like a huge part of this process. Why would you lose your job if and like just skip that question? I'm like, well, I don't. It's challenging to me if we can't discuss that openly here, and you can't be open to with others that you have this issue, and you don't trust me enough as a provider. You don't trust the system. It's actually having the opposite effect, right? So we're sitting here saying, let's be more open about substance use so you don't have to hit rock bottom. But then the system around us is forcing you to wait till you hit rock bottom before you get help. Or else if you prematurely get help, you might get penalized for it, right?
Right.
There might be negative consequences. And then that discourages people.
And it's not like these populations of professions are devoid of these issues. You've just shoved people in a closet. It's not like
Yeah.
people who are pilots don't have mental health issues. It's not like cops don't have mental health issues, substance abuse issues. The same healthcare concerns that affect one person can be viewed at a macro level. People are not that unique. It's one of the things that we say in programs, in substance abuse programs. You're not unique.
Yeah.
Everybody in here was where you were.
Right.
And it's interesting you said that, like, only recently have we started talking about relapse being a part of the process of recovery. They've been saying that in AA meetings, NA meetings, all the 12-step programs
Right.
for decades. They have been
For
saying the
sure.
13th step is going to be a relapse. And the only question you have to contend with is, do you want to hit the 13th step? And if so, how many times do you need to do that before you can finally fully lean into a program? Are there some drugs that are harder to come off of than others, or to acknowledge that one has a problem with than others?
Yeah, I think from my experience, methamphetamines is probably the hardest
So the
substance use
drugs I'm on,
disorder.
basically, for ADD. Go ahead.
Well,
I'm
no,
here for it.
more like no, more like crystal meth.
Okay, different level of I'm like,
Yeah.
am I meant to, like, throw out my concern right
No,
now?
no, no, no.
Okay.
I mean, so stimulant disorders and cocaine use disorders, certainly not easy. And if someone is self-medicating, they should be on prescribed medication. We also see it for that class, contingency management, where you reward somebody for being sober has been effective. There's also a vaccine now that they're exploring for cocaine use disorder that's in trials. So that'll be interesting. But I'm not talking about any of that. To answer your question, though, crystal meth for me was and is the hardest to treat in terms of getting somebody sober and feeling confident that they won't relapse. Because one of the ways that we help an individual if they're self-medicating is to put them on prescribed meds,
Mhm.
right? Or we use other medication to decrease cravings, or target similar receptors. And we can't do any of that for crystal meth. The response that you get and the high that you get from crystal meth is untouchable.
Wow.
So if I used to have a lawyer who was on meth, and we tried to replace that with controlled substances, prescribed medication, and then he's like, I can produce 10 times the work in an hour if I take my meth. I was like, I'm sure you can. I don't know. You become
So rough.
you become superhuman. And he's like, well, if you can't get me to be that effective at work, I'm just going to continue. I was like, that's you've touched
Uh,
something that I have no way of competing with,
Yeah, I was just gonna
and
say that's a competition you can't win.
no, no, it's until, and then he started losing a lot of weight and got very sick and wouldn't sleep and wouldn't eat because of it. That's going back to the rock bottom that you're talking about. But it took him losing complete control. At first, he felt so productive and so effective, and was
Mhm.
resistant to participating in treatment until he saw himself deteriorating right in front of our eyes. But I would say, of all the substance use disorders, meth is probably the most difficult to treat. And then we also don't have as many options, right? You look at alcohol use disorder. We have tons that we can give alcohol use disorder, right? You can give them naltrexone, Cambrol,
Mhm.
and abuse, right? There's stuff. If someone can't take their meds every day, they can come in for a Vivitrol injection.
Right.
There's things we could do, right? Same with opioid use disorder, right? When Suboxone came out, it was a game changer,
It was.
and now if someone can't take their Suboxone, you can give them Sublocade. There's more to work with, so we can help people. There's not much we can really help people with meth use. So it could be that could be a reason why it looks like it's so difficult to treat because we don't have as many options. Back in the day, people used to say heroin was impossible to treat.
They
Right?
did.
When I was growing up, it was heroin that if you touch it, it's the end of the
One
world.
time, you're done.
One time and you're done, right? That was when I was a kid. That's what they said. But now people are at methadone clinics doing great. So maybe that'll change. Maybe the landscape for meth use will change, and that won't be it won't be as challenging. But right now, it's still quite challenging.
When it comes to recovery, is there a level of innate natural resilience that an individual may or may not have that makes them a greater candidate for recovering appropriately?
I would say anyone could achieve sobriety and recovery, and we must lead with that mentality. Must. Everyone should believe they can if they want it. It would be very dangerous to start suggesting that you're not a candidate for recovery or sobriety. That said, I could explore why one person gets there sooner, is more successful, has less relapses, and it has nothing to do with wanting it as much as it has to do with resilience. That's the first part of your question. How resilient are you to bounce back? How soon can you bounce back? That kind of tenacity and that persistence will help you get there sooner. But I also don't think it's a race. You're competing with yourself. I've had people achieve sobriety in months. I've had people achieve sobriety in years. I've had people maintain sobriety in months, and that's a huge success. I had people maintain sobriety for years. So you very much compete with yourself. And I think the tenacity and the persistence is very, very important. You almost have to be stubborn in a sense where you will become sober, right?
I
And
was
believe
wondering
that and want that.
if being neurotic might be an asset when it comes to
If
um
channeled correctly.
right. I don't like this language, by the way. I'm critiquing myself as I'm speaking because I worry that there's an implication that this is behaviorally driven. And I'm with you when it comes to this is a disease. Addiction is outside of people's control. People are not choosing to be addicts. It's an illness that needs to be treated like any other illness. However, I would be full of shit if I were to ignore the fact that there were some common traits, personality traits among clients that I have or that I've had over the years who they threw themselves into the work. And whether they went to a medical professional or not, they went into programs. They committed to doing a 12-step program. They did a 90 and 90, which is 90 meetings in 90 days. So for 90 days, it's 3 months, they don't miss one meeting. And it's astonishing how effective that can be when it's the right moment and all the things line up well for the person.
Certainly, we know that physiologically, their addiction and substance use disorder isn't a choice, right? And we know that. We know that people that are dealing with substance use disorder have predispositions, and the effect of a substance can hit someone differently, right? Not no two people are the same in that sense. But what I do tell people is you didn't choose to have substance use disorder,
Hmm.
but you are choosing to become sober,
Yeah.
and you are choosing to be in recovery, and you are choosing to be here. And when people tell me, well, no, I'm court ordered to be here, or I'm here because I'm for my girlfriend or my boyfriend, that's a very dangerous place to be because I need to bring that person to the point where they want to be here. And if they tell you, well, I didn't choose to have an addiction, true, but I need you to choose to be here and want to be here. And if you're not
Yes.
ready, I can't want this more than you. And if you're going to tell me that addiction is a disease, we're not talking about addiction. We're talking about becoming sober and recovery. And we're talking about you wanting it. And there have been times where I told people you're not ready. And what's
Yeah.
interesting is, with motivational interviewing, you try very much to get the person to see their substance use through your lens and want sobriety and all that. But I've noticed sometimes when I've said, when I've effectively given up in the conversation and said, forget it. It's not for you. Come back when you're ready. Those people boomerang back really
It's
fast.
literally a different clinical intervention that you unintentionally use when you let go of your end of the rope.
Yeah,
It's called joining the resistance, and when you
it is.
let go,
The rolling
yeah,
with the yeah. So
yeah,
rolling with resistance is exactly it. And it happens. It actually happens quite organically. It's not like
I believe it.
it's not like in the conversation. I'm like, this is a very good time. I'm gonna roll with the resistance.
100%.
Sometimes I'm like, you're
I'm
very
out.
difficult.
I'm out. Or
You're
this
very different. Like, yeah.
situation is, I don't see a way out of this. So maybe we have to agree
Yeah.
to disagree. And maybe we can both
Right.
agree that it's not the right timing. And then the other person can move closer and take a little bit more responsibility for their
Absolutely.
recovery. I spent the first 15 years of my career working with teenagers. Teenagers back in the 90s rarely decided they just organically wanted to go to therapy. There was usually some compulsion behind them, an invisible gun behind their head from either a coach, a school, a parent. And I knew innately, because I was such a difficult teenager, I knew there was no working with a kid who didn't want to work with me. So, what I would say to them is, I get that you're not here because you chose to be here. I get that someone is requiring you to be in therapy. What I want you to know is this: I'm going to spend 2 hours with you doing an assessment. At the end of that, if you don't want to work with me, that is your choice. I don't care what your parents say. I will respect your choice. I will make sure you leave here with 3 other referrals and we'll find you a different place. This has to be your choice, or I will
Yeah.
not work with you. And over the course of 15 years, I did not have one kid say no, not one,
Because
because
you've empowered them, right? That's the power that I think we've stripped a lot of people with substance use disorder. That you had your chance to get sober and you've lost it, and a lot when that's just doesn't make sense. They had their chance to get sober when they had no control over their situation. Now they're here. Now you need to empower them to decide what they want to do, how they want to do it, when they want to do it. It's ineffective to now try to force them into sobriety and recovery, and it's just ineffective. That's why these abstinence-based programs where you're not allowed to use for the duration of the program, it's very
yeah,
punitive. How how
yeah,
does
it
how is
really
that how
is.
is that person supposed to feel like supported in an environment where they're understood? And I've worked at both types of programs. I've trained at both types of programs. Abstinence-based programs made me very uncomfortable.
That's
You know what it's
interesting that
like
you
if
say
someone had
that.
months of sobriety, and then we tell people be careful of people, places, and things, right? That could attract you to substance use. Someone went to a party or ran into their dealer or was triggered. Now I have to kick them out of the program. Months of work, of
Right.
therapy, of groups, of med management, of adherence to the regimen and treatment plan. We're just going to throw that all out the window. Never sat well with me. And I don't think that's the future. I think we know data shows harm reduction programs are the way to go, and they create an environment where the motivation to become sober is intrinsic, and it is their choice, and they're empowered to continue and do well and succeed.
This seems like a good point for me to ask you to clarify what harm reduction is. But before you do that, I want to just provide a little bit of context. Back when I worked directly in the field of substance abuse, recovery was very much a binary concept. You were either abstinent or you were an addict still using. That has changed in recent years to include this option called harm reduction that you've referenced a few times. Can you explain what harm reduction is and how it's come in to our current zeitgeist?
Well, first of all, it's the acceptance that somebody, even in recovery or attempting to achieve full sobriety, might pick up, right? You start with the idea that you accept that as a reality. Juxtapose that with an abstinence-based program where you must abstain from using from the minute you declare that you're going to be sober or you're going to pursue a recovery program. So you don't have to declare that in a harm reduction program. And harm reduction can manifest in different ways. You could see in some cities around the world, safe needle use. And if somebody, I mean, we don't see the new generation really using needles as much as we used to. Most opioid use disorder is now without needle use.
Hmm.
So it's not as common, but when it used to be, programs where you could inject safely in a place where you're not judged is a form of harm reduction. Being in a rehab program where if you pick up or you use or you drink, you're not going to get kicked out of the program or be penalized is a form of
Because
harm reduction.
historically, what we would do is we would drug test people in order to be in an outpatient program. Inpatient, you didn't have to worry about it. But in an outpatient program, which I ran many of them over the years, we would randomly drug test people. They would
Okay.
consent to it. And if they came up with a dirty urine, there would be a certain number of strikes and then they'd be out, or maybe not any strikes whatsoever. And then they'd be out.
They're the ones at zero strikes.
Hmm. Right.
The harm reduction places, could do some strikes and you try to do less and less and you work with the person. I think the biggest takeaway with harm reduction is you work with somebody to help them achieve sobriety. There's the notion of meet them where they're at. For example, we give people naltrexone for alcohol use disorder. And sometimes they do still drink and their cravings decrease. And if it was 2 bottles of wine, after a couple of weeks, they're drinking a bottle. After a couple of weeks, it's 2 or 3 glasses. After a couple of weeks, it's 2 glasses. In a harm reduction program, that's considered a victory.
Yeah,
You're
it's
you're making
huge.
excellent progress.
Yes, it's a home
In an
run.
abstinence-based program, you're a failure.
Hmm.
So really creating an environment where we understand that you are trying your best, or you at least give the person that benefit of the doubt, creates a space where they're motivated to achieve sobriety in an environment where they won't be penalized and it isn't kind of retaliatory.
I have found in life, particularly my professional life, although I could argue my personal life as well, that giving people choices just makes life so much smoother. It just make it,
Hmm.
I can't, otherwise we as the healthcare providers are pulling all the weight. We're the only ones invested. If a person doesn't have choices and options. So tell me how harm reduction works for I think you either alluded to this or maybe you outright said this, person-centered care. What does that look like?
Person-centered care, individually focused, kind of customized treatments. That
That's
that
right.
is
Yeah,
where we're
that was it.
headed, right? That is the future. I think it goes back to what I was saying before, understanding what is your substance of choice? How often are you using? How willing are you to cut back? What depending on the medication you're on too, there are medication where you have to abstain. And there are serious risks and consequences if you don't. But understanding all that, right? You add that to the picture that you're on a medication that you could use versus you're on a medication that if you use, you're going to have terrible withdrawals or get very sick, or they could be lethal. But you paint that entire picture for the individual. And let's say somebody says, there's no way I could stop using. Well, then these medications are not for you. You're not ready for that. But this medication is for you because here you could periodically use and will slowly cut back. So when you're really kind of patient centered and really trying to assess what the appropriate treatment is, you are intimately familiar with the person's patterns of substance use, their drug of choice, their frequency, right? Things like that. When you compare that to back in the day when you had rehab programs where everyone had the same treatment protocol, it becomes probably easier logistically. You just put everyone
A
on the same
hundred
treatment
percent
protocol.
easier. Oh my God, it's so much, it's a rinse and repeat. You don't have to use your brain.
It is. Well, you just kind of go through the mill, right?
Yeah.
But some people make it and do well. Some people don't make it. Some people do worse. It's treating everyone like a collective, which if you're really kind of looking at outcomes, very bad.
So do you not at Mindful Care, do you guys not drug test people?
Even in harm reduction programs, we do. It
Okay.
isn't that you don't, but that's a part of the conversation, right? It's a part of the process. I've been in harm reduction programs where someone has been clean, right? Or let's say we don't use the term clean and dirty anymore. We use negative or positive. So they've had a negative urine toxicology screen, but suddenly a new substance appeared.
Mhm.
And it's a great opportunity to have a conversation. Be like, all right, so we're doing really well. You haven't picked up what we're here for. So that's great. But care to tell me if you're experimenting with something new? And they do. And you have that conversation. So urine toxicology screens are a part of the process, but they actually become a part of the conversation and an opportunity for the person to demonstrate and measure themselves, for you to measure them, versus I'm out to get you. Be careful, or else I'm going to catch you. If you lie to me, I'll figure it out. Becomes a very adversarial relationship, which is how U-toxes were used in the past, right? You
Yes,
had
they
to do
were.
observed U-toxes and be like, oh, I caught them. You lied to. Now people actually in harm reduction programs, they'll tell you that it's going to come up positive. They're like,
Mhm.
by the way, I did the urine tox yesterday. Didn't get a chance to tell you, but I used last weekend, so I don't want you to be surprised, and appreciate it. Appreciate you being honest and telling me. And it just there's a partnership towards sobriety and recovery, which is much healthier.
It used to be used as a disqualifier. It was the
Right.
thing that if you came up positive on a drug screening, it was either a strike or you were out, but it was counted against you.
Yeah.
Do you guys still supervise drug screenings? Do you go
I
to
was
the
just going to
bathroom
tell
with
you, I
people?
was going to tell you that the need to supervise is a lot less, right? The monitored or the supervised UTOX used to be a thing because they were so scared to come out positive that
That people
they
would
would,
purchase or borrow somebody else's urine who was more likely to
yeah.
be negative.
So now, I mean, there are programs that still supervise, and there are in some cases where it's appropriate to supervise, but not as aggressive as it used to be.
Got it. Do you guys supervise it?
No. Well, we send to a lab, so whatever
No, but I
protocol
mean
they do,
no,
whatever the
the
protocol they do at
sample
lab for.
itself. Like, no, do your clinicians walk in the bathroom the way I used to
Right.
and
No,
stand
no,
there
no,
while the person's
no,
urinating and giving you the sample to make
no,
sure it comes from their body?
no.
Because something that our listeners may not even know is that the little cups that you pee in, they have thermometers on the side, and we're meant to look to make sure that it's body
Yeah,
temperature because people
right.
used to come in with a little cup of someone else's urine and dump
Yeah,
it
and it
in
would
there.
cool off by the time for sure. Yeah, we don't do that
Yeah,
anymore.
I'm really glad to hear that. What do you think about people who identify as addicts but never go into a program? Does that feel to you like a relapse just waiting to happen?
No, and yeah, I don't even use the word addict any really that much anymore. You know, it's for maybe I've been conditioned not to, but it's just an individual with substance use disorder. Um, the way an individual has hypertension or high cholesterol or depression or anxiety. But let's say even if someone identified as having substance use disorder without being in a program, I'm okay with that. I think this is it's their journey. You know, I've actually had this with people who identify as alcoholics. Right
Mhm.
now, the correct term is alcohol use disorder. But if you identify as an alcoholic, I'm gonna correct you about the term you use to describe yourself. I mean, describe yourself however you want. If in your head you're an alcoholic, whether you meet the DSM-5 criteria of alcohol use disorder or not, who cares? Who cares? If for you one glass a night is too much and you think it's a problem and you want to be in a program or don't want to be in a program or you found a way to help yourself and it's been effective, I support all of it. You know, I think really empowering an individual if they identify as having an issue and have found a solution, whether it's through one of our programs or through rehab or through detox or through a 12-step program, through having peer support or whatever it is. If they feel that they're in a better place because they were able to help themselves somehow and identify as previously having an issue, all the power to them.
You don't worry that the same behaviors and ways of thinking and unhealed wounds, if they go unhealed and the ways of seeing the world go unchallenged, that the person is literally just white knuckling their way every day.
Yeah, it's an interesting thought. I guess depends what you're envisioning, right? And I think if you're envisioning someone with a very mild case of substance use disorder, and they figured it out, probably the risk is low. If it's someone who's had severe or moderate to severe substance use disorder and wasn't properly supported, then I could say that they've achieved sobriety with probably a lot of band-aids and a lot of unaddressed issues. And that could be much more of a muscle play, right? They're muscling through their sobriety. And that is for sure a lot more challenging for the individual, but also puts them much more at risk, right? Because in that scenario, I think if they weren't given the tools, they
Mhm.
haven't done the work, they don't have medication to support them with cravings, that becomes very, very difficult. That is really muscling through to stay sober every single day. That's fighting quite a fight. But I was originally picturing someone with a mild case of substance use disorder. I've heard many people, not need programs, not need detoxes, and do fine. But the severe cases, if you're doing it solo without support, sounds very taxing.
And I've seen it bite people in the ass so many times that
Mm,
if somebody identifies themselves as having a substance abuse problem when they're working with me, I always encourage them to go to a program because the support that they need and deserve, like substance abuse is a big problem. It's a contagion, and we live in a society where they're constantly going to be exposed to it, even if they
yeah, it's
change
even worse.
people,
It's even worse
places,
now. It's
and
even worse now.
things.
We look at cannabis use disorder. I'm against adolescents using cannabis. Brain development goes into your 20s. You have these kids saying, "But it's legal. Why can't I use it?" We don't have any real FDA approved or effective treatment for cannabis use disorder. There are in Europe, there's some kind of THC receptor analogs and agonists that are
Mhm.
still kind of being studied, and it's still unclear. So there's nothing I could even really do to help you that much unless you're self-medicating, then there's a ton of stuff you could do. But the point there though is it's in your face. You walk around Manhattan, every
Yes.
other store is a CBD, and all this stuff is just thrown at you, and it's been normalized. What are you supposed to do? They say people, places, and things. Well, what if it's ubiquitous? What are you supposed to do?
Right. What if it's, like, as prevalent as alcohol, which weed certainly is
Yeah,
becoming?
right.
I am curious, how did you pick your profession?
So during residency after med school, I did general adult psychiatry residency and felt that there was a patient population that was pretty neglected, and that's the substance use disorder patient population. Felt there was a lot of stigma. Actually, thought they were being treated differently, even by healthcare professionals in the hospital, and it seemed as though the consensus was that it was a choice. And even though we know it's not, and if you ask anyone, they know the correct answer that it's not, I felt like we were still treating them as if it was a choice. And that bothered me. I felt like it was a very misunderstood patient population. And I was very curious to understand, how did you end up in this situation? Right? What is going on in your life that you lost control, that you have to turn to substance use? And is there a way out? And I was really fascinated by what's going on and how can I help. And then when I started learning more about people's stories, whether they were self-medicating, whether they were going through a lot in their life, or they were trying to deal with trauma and weren't able to face it. Once I understood a little bit more and I was able to help them, seeing what it meant to turn their life around was very moving. It's different than, especially in psychiatry, if you're able to help somebody who's managing schizophrenia deal with their schizophrenia, that's one thing, right? They could be a lot more high functioning, and it is very positive. But the drastic change that I saw in patients that were almost incapable of being productive
Mhm.
to going back to changing the world, that shift, I was like, I really want to help more people like this, and keep doing this all day. And it just, there was, I felt it very rewarding not to say other specialties in psychiatry aren't rewarding, but for me, it was that drastic shift meant a lot. And also how grateful these individuals were, right? Everyone else wouldn't look their way, would dismiss them.
Hmm.
And I took the time to get to know them. I felt like I really want to work with this patient population. And here I am now.
Were you yourself drawn to it for any ancillary personal reasons? Did anyone in your life struggle with addiction?
Not at the level that I treated. I've had connections to mental health in my life that attracted me to psychiatry, but the level of addiction that I treated, particularly opioid use disorder, alcohol use disorder, at the level that I saw it, it started to feel very personal because I started to hear all these stories that I connected with more from the empathizing with the inability to cope and navigating and finding substance as an outlet. I was able to empathize with the frustration. And I think
Yeah.
that that resonated also with the care that I provided because it wasn't robotic. It was very genuine and authentic in that it totally makes sense. Meaning, I think anyone in your situation would have reached for the bottle too, because what you went through is horrible. And I
Hmm.
mean that. And now let's get you out of it together.
It's not lost on me that the opioid crisis must have been bubbling up or in full eruption when you were graduating. Am I tracking your timeline, your
Yeah.
professional timeline, right?
Yeah.
And
Yeah.
I remember very early on, I I was hearing Steph, my wife and I, who she now shares my practice, but back then she was my employee and my friend. We were getting referrals from high schools in New Jersey in 2006, 2005, even 2004 for opioid overdoses, and we were running grief groups because of it.
Hmm.
And, just add 20 years onto that, now we all know about the opioid crisis. I
Yeah.
can absolutely imagine how you felt so pulled to help folks.
Yeah, it felt like I mean, a neglected community. It was before we had Narcan everywhere. I mean, now most people who have substance use disorder or have had relationships with people, I mean, it's much more accessible for sure. So people are a lot more educated in terms of overdosing. Schools, universities, right? There's just a lot more awareness. I was probably at that point where the awareness was changing
Mhm.
and felt like I could really be at the forefront of having a positive impact. Now if you look at opioid use disorder and its treatment, you have tons of people on Suboxone that have years of sobriety. You have people on
Mhm.
Sublocade and long-acting injectables for opioid use disorder. It's not what it used to be. And there are many very high-functioning, successful individuals that you would never know have ever had a problem with opioid use and now are in recovery and celebrating sobriety and things are great, so it's come a long way. But when I first decided to pursue substance use disorder treatment and addiction psychiatry, it really felt like a marginalized group that I just wanted to get in there and figure out what's going on. Maybe people are right. Maybe there is a reason these people aren't getting the attention they deserve. Maybe they're wrong. I was just very curious and fascinated. And it was a really rewarding and still is a very rewarding experience.
Dr. Tamir Aldad, thank you so much for this conversation.
Absolutely. It's always great catching up with you. Thank you for having me.